Welcome everyone. Let's give it a couple more minutes as everyone comes in and settle in before we launch the webinar. Good afternoon to every single attendees. All right, it is 1 p.m. PT. Let's give it maybe another minute or so, and we'll kick off. Thank you. Okay, attendees are tapering off. I think it's good for us to start. First off, good afternoon, welcome, and thank you for joining our webinar this afternoon. This is Lornie from Lumenis, and I would just like to give a quick introduction as to who we are and who our presenter for the day is. We are Lumenis. We are the world's pioneer of SLT technology, and our flagship system, Smart Selecta Duet, combines the advantages of SLT with the capacity of YAG, photodisruption, while also allowing titratable vitreous opacities illumination on axis or off axis. We basically invented SLT for glaucoma treatment, and for today we have Dr. Nate Lighthizer, who will be expanding more on this technology and how it could benefit your patient and provide them better patient care. So Dr. Lighthizer graduated from Pacific University College of Optometry. Upon graduation, he completed a residency in family practice optometry with an emphasis in ocular disease through Northeastern State University, Oklahoma College of Optometry. He lectures nationally on numerous topics, most notably advanced ophthalmic procedures, electrodiagnostics, and ocular disease. So without further ado, Dr. Nate Lighthizer, thank you so much, and floor is yours.
All right, thank you, Larnie. Welcome everybody to all of our attendees for our webinar this afternoon. So I want to thank Lumenis for inviting me to lecture and talk on SLT technology and really just have a discussion with all of you guys. If you have questions, we will have a question and answer session the last 10 or 15 minutes of this hour. So I'll lecture or talk on SLT for the first 45 or 50 minutes. But if you have any questions at any time, please type those questions into the question area that you can see on your screen there about anything regarding SLT or laser therapy for glaucomas. I'm happy to answer those at any time. So excited to be here. If you don't know, again, I'm Nate Lighthizer. I'm a faculty member at the Oklahoma College of Optometry at Northeastern State University in Tahlequah, Oklahoma. I've been here for 11 years now. Hard to believe, 11 years. I did my residency back in 2009 and 2010. And have been on as faculty for about 10 years since then, where I head our specialty care clinic, where we do all of our laser procedures, whether it's capsulotomies, iridotomies, SLT being a big one as well. So today's topic, we're going to talk about SLT for the open angle glaucomas. And we're going to hit this from both a treatment perspective as well as a referring perspective as well. Again, I know we have mostly ODs on the lecture or on the call today. And many of them may be able to do this procedure, whether you're in Oklahoma or the other states that allow optometrists to do this, or even if you're not, we're going to tailor this to the referring doctor as well of when should we consider SLT in our glaucoma treatment armamentarium. You know, we know what traditionally it's been is you considered laser trabeculoplasty, specifically ALT, when it was came about in the late 80s and in the 90s and early 2000s. ALT was after maximum medical therapy, whatever that was for that patient. You know, where do you consider that for SLT? We'll cover that among with any other many other topics as well. Again, let's keep this as interactive as we can for a webinar. If you have any questions, please type them in. You know, I'd really like to engage the audience as much as we can. Speaking of engagement, if you've been to my lectures before, I love to poll the audience. We're going to do that. We can do that via poll everywhere. So I'd like everybody to get their phone out or their iPad, whatever you're connected to the internet, and open up a browser and type in pollev.com/my name, Nate Lighthizer. I'm going to ask you guys 3, 4, 5 questions throughout the next 45 or 50 minutes. And it's a great way to poll the audience and just see, what are you guys thinking? It is completely anonymous. Nobody will know what you're thinking or what you answer. I won't even know what you're answering as well. So it's completely anonymous. Nobody knows your answers, but it's very interesting to see, you know, what percentage of people are thinking this versus this versus this versus this with no individual answers. Again, nobody will know what you're putting. So again, I encourage you to open up your phone, open up a browser and type in pollev.com/my name, Nate Lighthizer, and that should bring up my poll everywhere page. And our first question is, there's no wrong answer to this one, is when do you most often utilize SLT in your practice, either doing it yourself or referring for it? And again, let's see what those answers are. Is it first line therapy? Is it after 1 drop? Is it after maximum medical therapy, which is 2 or 3 drops? Or is it never? Let's get a kind of a nice general sense of where we are utilizing SLT in your practice. Again, poll, if you haven't logged in yet, it's pollev.com/Nate Lighthizer. You can see that up there at the top. All you have to do is hit the button. It will automatically register your response. When do you most often utilize SLT in your practice, either doing it or referring for that procedure? Is it first line therapy, after 1 drop, after 2 to 3 drops, or never? And we've given it, I think, enough time. So I'm going to come over here and hit a button and show the responses. And there we go. Okay. And you guys can see the breakdown. And I think there's good news and there's bad news. And there's really no bad news at all. But, you know, after 2 or 3 drops, maximum medical therapy, answer number C. Well, certainly it's not wrong. And traditionally speaking, that has been the answer. Once my patient is on maximum medical therapy, which is usually 2 or 3 drops, that's when we considered laser trabeculoplasty, specifically ALT. I would encourage you guys to really look at the literature as we go through this, that SLT has been proven to be first-line therapy, an option for that for many. And I think that's why the good news is we have 25% that are now considering this as first-line therapy. and we'll talk about when SLT is most effective. I think that's a key on that, is when is SLT most effective? How do we predict success? How do we choose the patients that, boy, it's likely going to work well in you and it's not going to work very well in you? How do we do that? So we're going to talk about that in just a little bit here. So again, I just wanted to get a feel. I think you guys can get a feel for the docs out there that have answered this question when you're utilizing SLT in your practice. The majority after 2 or 3 drops, but we have got 43% either first line or after 1 drop as well. So again, when we consider lasers for glaucoma, for open angle glaucoma, I think there's a lot of variability. There's a lot of ways you can go. Unlike a laser for a cloudy capsule, like a PCO where you do a capsulotomy, or if somebody's got incredibly narrow angles and they're not ready for cataract surgery, they need a peripheral iridotomy. Those are pretty clear cut. With this, there's a lot of options. How many drops do we have available? We've got laser now, we've got MIGS, we've got cataract surgery, and there's other glaucoma surgeries as well. So when somebody's diagnosed with glaucoma, I think traditionally speaking, we all were trained, it's drops first, it's laser second, and then we go to surgery third. I think generally speaking, everybody would agree with that. Again, I encourage everybody on this webinar, look at the literature, the latest literature, and we're going to cover some of that, that SLT, laser trabeculoplasty, is moving and really is caught up to drops for first line therapy. Now, we don't push one over the other. We present these as options to patients, as we can go drops, we can go laser, and we'll go from there. So I think this is really the traditional paradigm. When it comes to glaucoma, it's been meds are first, and then it's been laser trabeculoplasty, and then it's been surgery. But I would encourage everybody, again, to think about that. Have you ever had issues with your patients in terms of compliance with their drops? And I think most people would say, yeah, we have issues. We have compliance issues. What percentage of your patients are 100% compliant? And when I lecture in person, I see a lot of people going 0. Very few are. Some are compliant, many are not. So I think we have to factor that in. We have to factor in cost issues. We have to factor in convenience, quality of life issues as well. How many of your patients are glaucoma patients and also have dry eye? And they're using a drop or 2 for glaucoma with preservatives that are exacerbating or worsening their dry eye or MGD as well. So all things that I think we have to consider, and drops have cost issues and convenience issues. And how many times have you prescribed an eye drop for glaucoma? The patient got to the pharmacy and it wasn't covered, you had a PA or things like that. So there are certain benefits when it comes to laser trabeculoplasty for glaucoma. Hitting on those, why SLT? Reiterating our point, a couple of funny videos that I always play to start. Here's our first one. And again, it's a funny video. Obviously, we know that's House. She's using her inhaler. She's compliant with her inhaler, but yet she's not using it in the appropriate manner. So even in a compliant patient, per the patient, things are still not going as we would expect them or as we would like them to go. Okay, that's not the eyes though. That's not the ophthalmic space. What about in our space? I want to thank my good buddy, Dr. Justin Schweitzer, for passing this video along to me. You take a look at this. They've done studies that have shown patients and saying, show me how you put your eye drops in. I know you say you're taking the drops, but how effective are you at getting the drops in your eyes?
That's too much.
We know many of our patients, and you can see the numbers at the bottom here, many of our patients that have open angle glaucoma are in their 70s, 80s, 90s, and just aren't as good at putting eye drops in their eyes as maybe somebody in their 30s, 40s, and 50s. Unfortunately, open angle glaucoma is a condition of patients that are in their 60s, 70s, 80s, and 90s. So again, there's been literature out there that has looked at the compliance of patients after the initiation of drop therapy, and you'll notice our most commonly used eye drop, prostaglandins, even that settles out. It's the best one, but it settles out at about a 30% compliance rate when patients have been on it about 12 to 18 months. So we know that there are issues when it comes to drops. This was one particular email that I received from a patient. This has been, again, a year or 2 ago, and you can just read this and you go, You know, is it possible if you recommend an ophthalmologist or an optometrist? I'm on eye drops for pressure. I've got glaucoma. Look at the quote. It's about to eat my lunch. It's a prostaglandin, dries my eyes out so bad, dizzy, difficult sleeping. I've tried other ones. This is the only one that lowers the pressure. I've talked with my doctor, the primary eye care doctor, about it. He wants me to stay on it. I don't intend to do so. Do you have patients like this in your practice? I would be willing to venture a guess that you probably do. So whether it's dry eye, whether it's compliance, whether it's cost, whether it's convenience, there's just a lot of advantages for laser trabeculoplasty when we consider that in our glaucoma treatment armamentarium. So laser trabeculoplasty, how does it work? It increases aqueous outflow, trabecular meshwork, aqueous outflow. And it was the only thing for a long time that worked on trabecular meshwork outflow. We know that prostaglandins work on uveal scleral outflow. Things like beta blockers and alpha agonists decrease aqueous production, but there was nothing for a long time that worked on trabecular meshwork outflow. SLT and ALT do a great job at that, both increasing aqueous outflow, trabecular aqueous outflow. And again, we've talked about this. Is it second line? Is it primary treatment? Historically, and it takes a long time to change a way of thinking. We've all been trained through optometry school, through our continuing education, through even our relationships with industry, which are so very positive, that we go to drops first and then we go to laser second and the surgery third. We've been trained that way through the 60s, 70s, 80s, 90s, and even to the early 2000s. That's the way it is. It's hard to change a mentality of 30 to 40 years of how we do something. But in other parts of the world, SLT has been first-line therapy for well over a decade. Places like Europe, the Middle East, eastern parts of the world like India, SLT has been first line for well over a decade. Now it's lagged behind in the States for various reasons, but laser trabeculoplasty is universally accepted. And it's universally accepted that it works, it's efficacious because of the glaucoma laser trial, among many others. But this was the first big one back in 1990 that compared ALT to the best topical medication at the time. And they found that ALT was just as good, if not better, than the best topical medication at the time. So ophthalmology took this, and rightfully so, and said, we have a laser that we can use usually after a maximal medical therapy, but it works pretty good. It works like one medication with ALT, and they started using that pretty heavily through the 1990s. What are the indications? And we're going to hit on this again with SLT. I'm going to spend about 5 minutes on ALT because you can't really cover SLT without comparing it to its predecessor, which was argon laser trabeculoplasty or green laser trabeculoplasty. Obviously, they have to have open angles, POAG, low tension glaucoma, ocular hypertension, pigment dispersion, pseudoexfoliation. Those are really the five. These four add in ocular hypertension. They all have open angles. We'll talk about the biggest ways you can predict success, so which patients you should select for an SLT versus which ones maybe you should not. But these are the four indications. Add in ocular hypertension as well. Contraindications are everything else. You know, if your patient has narrow angles or angle closure, you can't do a laser if their angle is relatively narrow or it's closed. The top bullet, advanced POAG. If your patient, this is a relative contraindication, by the way. If your patient has a 0.9 cup or a 0.95 cup and has advanced end-stage glaucoma, not saying you couldn't do an SLT, but that patient may need something more. They may need a tube or a trab or a MIG surgery of some sort. So it's not off the table, but it's a relative contraindication in advanced POAG. I've done SLTs in patients that refused other therapy, but it's a relative contraindication to do an SLT in somebody that's got advanced end-stage glaucoma. Can it be done? Yes. But you may want to refer for other procedures in that advanced POAG. Again, we talked about narrow angles and your secondary forms of glaucoma like neovascular, angle recession, inflammatory, etc. If they failed a previous SLT, we probably don't consider another SLT, as you can see there. Under 40 years of age was a bigger contraindication for ALT. That really has fallen off with SLT. We didn't want to damage the meshwork early in life with ALT. Now that we're not damaging the meshwork with SLT, as we'll talk about, really, I don't make any treatment decisions in terms of laser therapy with SLT based on age. I'm just as likely to do an SLT in somebody in their 50s or 40s or even late 30s Even though glaucoma is rare in those ages, I'm just as likely to do it there as I would in 60s, 70s, and 80s at that point in time. So here's our next question. Again, I'm going to spend about 5 minutes on ALT because it's the predecessor of SLT. How did ALT work? Now, we were all trained. If you trained through the 70s and 80s and 90s and even the early 2000s, we were trained in how ALT works. So how does ALT work? The main mechanism of action by which ALT works is what? Does it burn holes into the TM and aqueous flows through the holes? Laser burns, which cause scarring of the TM and mechanically contract the tissue, or biologic activation of inflammatory mediators, which clean up the trabecular meshwork. How does an ALT work? ALT is a photocoagulator. It's the same laser that you've all seen on the retina for PRP, on the iris for procedures like that. If they need to photocoagulate the iris, like ALPI and iridoplasty for plateau iris syndrome, it's a photocoagulator. It is damaging the structure that it hits, in this case, the trabecular meshwork. And the answer is, yeah, laser burns, which cause scarring of the TM and mechanically contract the tissue. And ALT basically does this. If you can see my hands here, it burns here, it burns here, and you get a little bit of coagulation contracting action, and it opens up the adjacent areas in between. Ask yourself this question: how is the repeatability for ALT? And the answer is what? Relatively poor, is it not? I mean, ALT is, because sooner or later you do this enough, and what do you run out of? Adjacent areas in between. Repeatability of ALT is poor, and that's a big advantage of SLT, because the repeatability of SLT is much better, as we'll get to. So ALT was the traditional. Main point I want you to remember is it's mechanical, is what they think of how this works. It burns and burns and scars and causes damage in the meshwork and opens up the adjacent areas in between. It carried a higher adverse event or a side effect profile than SLT does. They were more likely to develop inflammation, more likely to develop peripheral anterior synechiae, maybe even IOP spike as well, because there's more inflammation, more likely a trabeculitis, more likely peripheral anterior synechiae when you're talking about that. So the risk profile was probably higher for ALT compared to SLT. You can see some of the ballpark energy settings for ALT right there. Focus was critical. When you're doing an ALT, whatever you hit, you're going to crater, you're going to scar, you're going to damage the structure that you hit, whether it's the retina, which is intended for PRP, whether it's the iris, whether it's the trabecular meshwork. So focus is critical when it comes to ALT, of getting right in the middle of the TM, because that's where the laser burn needed to be. Usually the standard for ALT, I think this is an important point. What was the standard for ALT? It was half the eye. It was 180 degrees, because let's treat half. Let's not damage the whole thing. Let's treat half the meshwork. And then if we need more down the road, we'll treat the other half down the road. And the reason I bring this up is, okay, through the late 80s and the 90s and the early 2000s, for 15, 20 years, that was the standard for laser trabeculoplasty. It was 180 degrees. You did half the eye. So when SLT came about in the early 2000s, when we've had ALT for 15 years, what do you think the protocol was? Just naturally, well, that's the way we did ALT. Let's do SLT that way as well. So SLT started as 180 degrees or half the eye, and there may be a change, as we'll talk about in just a little bit, on how many degrees we do with SLT. But the standard for ALT was 180 degrees. It was approximately 45 to 60 burns. You spaced them out, and again, right in the middle of the trabecular meshwork. Post-op, again, we put in alpha-GAN, or brimonidine, pre and post check their pressure. We'll talk more about this with SLT in just a second here, but that was the post-op. See them back a week or two for follow-up, approximately 6 weeks for follow-up to see the full effect of the laser. But bottom line with ALT, does it work? Yes, it works. A good chunk of the time, you can see 80 to 90% of the time it works. SLT doesn't tend to be any more efficacious than ALT. However, it's easier to do. It's more repeatable, and that was the biggest thing. Is a lot of ALTs were done in the late 80s and 90s and mid 90s, but then when we needed to do it again, okay, we did it again, and it's not working as well the second time. It's not working as well the third time. Repeatability was poor for ALT, and that's the reason why you can see in the diagram the number of laser trabeculoplasties performed in the mid, especially the late 90s, early 2000s, really dropped off, because repeatability is not great, we're damaging the meshwork, we've got newer medications come about, but boom, it spiked in 2001. Why was that? Because SLT came about. And it's important to remember that SLT works differently than ALT, and that leads to my next question. First question on SLT here. The main mechanism of action by which SLT, selective laser trabeculoplasty, works is what? Does it burn holes into the TM and aqueous flows through the holes? Laser burns which cause scarring of the TM and mechanically contract the tissue? Or biologic activation of inflammatory mediators which clean up the trabecular meshwork? So we know ALT was answer B. It was a photocoagulator. It hit here and coagulated and hit here and coagulated and opened up the adjacent areas in between. That was ALT. Answer B was ALT. SLT is what? How does an SLT work? And we've got most of the answers coming in here. SLT works differently. Yeah, you guys nailed it. The majority, 3/4, it's biologic, it's inflammatory, it's sublethal photostimulation. Sublethal meaning there's no coagulation, there's no destruction of the tissue. Sublethal photostimulation, meaning light is stimulating the immune system, inflammatory, biologic, macrophages, cytokines. So again, the exact mechanism is unknown. All the studies say that, but we know it's biologic, we know it's inflammatory, we know it's photostimulation. Basically, light or laser is stimulating the immune system. I always tell patients this when they ask, so how does this work? How does this laser work? I say, think of your eye like a sink. There's an area of the sink, the faucet that produces the fluid. There's an area that drains the fluid, the drain. Your eye is exactly the same. There's an area where the eye fluid is produced, and there's an area where the eye fluid is drained. The problem most often in glaucoma is the drain. The drain is clogged, it's not draining as well. There's all this junk and debris there. This laser is working on the drain, and it causes no damage to the drain, but it recruits your own immune system. When you're sick, what fights that? Your immune system does. Your immune system fights illness. Well, this doesn't cause illness of the meshwork, but it stresses the meshwork just a little bit, and that recruits macrophages and cytokines and all these, the phagocytes, all these immune cells that come up and clean up the cellular debris. And doesn't it make sense in theory that we should be able to do that again and again and again over? So in theory, it's more repeatable, and that's absolutely what the studies are showing as well. So think biologic, think inflammatory, think light therapy, light stimulation of the own immune cells that clean up the junk, the debris in the trabecular meshwork. Excuse me. Just showing again the electron micrographs of the ALT on the top, the damage, the pit, the crater, SLT on the bottom. Here it is again at the highly magnified level, showing it cleans up that cellular debris, enhances trabecular meshwork outflow as well. Again, the original laser was by Lumenis. The Selecta 2, it's the laser that I was trained on, and it's a frequency doubled laser, and it's selective for pigment. Remember, selective laser trabeculoplasty, SLT is selective for pigment. It's selective for pigment or melanin, so the more that they have, we need to change our settings, but we want some pigment there because the laser needs some pigment there in order to work. The less pigment they have, we usually turn our energy up when it comes to SLT. So how does it work? You know, stay with me for just a minute on this one. It's not the most exciting slide, but it's important to recognize, how does an SLT work? Pigment in your body, in your patient's body, it's going to take a certain amount of time to absorb laser energy and convert that to a burn. The thermal relaxation time, or basically the time it takes for pigment to absorb a laser, is 1 microsecond. So if a burn is longer than a microsecond, it is going to be a burn. The pigment's going to absorb the laser energy, it's going to transmit it laterally and cause a destruction of tissue or a laser burn. ALT, PRP, there's photocoagulation, there's burning there because the pulse duration is longer than a microsecond. Look at the pulse duration of SLT, 3 nanoseconds, and it's fixed. You can't change it on the device. Makes it very, very simple as the treating clinician of what you have to dial in. There is no pulse duration button. There is no spot size button. They are fixed. This is fixed at 3 nanoseconds, which is shorter than the thermal relaxation time of melanin. So there is no burn. This is a cold laser. There's no thermal destruction or thermal damage because of how quick the SLT pulse duration is. As I like to say, Everything with SLT, how it works, why it's biologic or inflammatory or a photostimulator, whatever you want to call it, that's how an SLT works. That's why it works. It all hangs on the pulse duration because of the 3 nanoseconds. It's so quick, and the thermal relaxation, there is no burn, there is no destruction because of that. It's a great mechanism of action, and shouldn't we be able to recruit these cells again and again and again because there's no destruction? We're not relying on the photocoagulation. SLT, much more repeatable in theory, and the studies are showing that now as well. So right away when this came out about in the early 2000s, don't remember anything on this slide, but you had to prove it wasn't inferior to what we already had, which was ALT, and absolutely it wasn't inferior, works just as well, and SLT took off in the early mid 2000s to be used like ALT. Again, ALT's been around for 15 years. We've used it after 2 or 3 drops. We've done it 180 degrees. Wonderful. Now a new laser came out. Let's use it after 2 or 3 drops. Let's do 180 degrees. That's how SLT was implemented in the early 2000s, mid 2000s, even late 2000s. When I was trained, we did SLT 180 degrees. We did SLT after a drop or 2 or 3. Was that the best way to do it? Again, I'm going to challenge you to think on that, and we'll talk about that actually right now. So here's to me the question in 2020. We're approximately 20 years in to SLT for open angle glaucoma. Where should you use it? I asked the questions. The reason I started this lecture on where do you guys utilize SLT? 55% of you were after the 2nd or 3rd drop. 25% were first line. We had about 17 or 20% that were after 1 drop. So you can see we hit most of these, but the number 1 was after the 2nd or 3rd drop. When do you think SLT works best? And I'll challenge you in that question. We're going to come to that in just a few seconds here. So here's your patient, 60-year-old male that comes into the office, and you take a look at this and you can see that obviously this patient that's a 60-year-old male hasn't had an eye exam in well over a decade. It has no prescription, doesn't need any glasses or anything. So hasn't been examined for a while. His wife drug him in. He's 60 years old, and he's obviously got superior rim thinning. And we've got a visual field that matches. Pressures were, I think, 23 or 24 or 25. We've got obvious glaucoma here. He's never been treated before. What should we recommend as first-line therapy? Let's see what the literature says. So this was the first big study that I'm aware of in the United States, done in the United States and released in the United States, that directly compared SLT versus prostaglandins for initial therapy, first-line therapy in a prospective randomized trial. This was done at Will's Eye by Dr. Jay Katz, big name in glaucoma. Obviously, you guys know Will's Eye. It was the SLT med study. Hard to believe it's been almost 8 years since this was released. And this was the study that changed our thinking on how many degrees should we do for SLT. Again, there's been other studies as well, but ALT was how many degrees? 180 degrees. SLT is now recommending for 360, not for all patients, but for the majority of patients, 360 is the general consensus for how many degrees we usually do. Again, not always, but usually. This was the study. You notice they looked at this SLT, about 100 applications over 360 degrees of meshwork versus a prostaglandin analog. Looked at primary measure, how much did it lower the IOP? Secondary measure, the number of treatment steps. Basically, they said this was randomized. This was placebo controlled, or I should say the placebo was the drop, but it was randomized, multi-center study. And it looked at, you can see they went down 2 arms. One group was the SLT group, 360 degrees, 100 shots in both eyes. Group number 2 got randomized to a prostaglandin therapy as first line. If they saw these patients every 2 months, they saw them every 2 months, and if the patients didn't meet the target IOP, they got more therapy. If they went down the laser arm, they got more laser. If they went down the drop arm, they got more drops. So that was the number of treatment steps. How often did they need to be retreated with a drop or a laser during the study? Here's what they found. Again, the study released out of the US, IOP reduction. First line therapy, SLT, 26% IOP reduction, prostaglandins, 28% IOP reduction. That did not reach statistical significance, so they were what? They were equal, they were the same. Outcome number 2, the number of treatment steps, the SLT group. If you went down the SLT arm in this 1-year study, 11% of patients needed more SLT. If you went down the drop arm, if you got a prostaglandin, 27% of the eyes, more than a quarter, had to get more drops. That seems significant. If you had to get drops, you usually had to get more drops versus the laser, but there wasn't a big enough N number, so it didn't reach statistical significance. So outcome number 2 was also equal. They were the same. So here was their ultimate conclusion after this, again, 9 to 12 month study. More treatment was needed in the drops, likely because of compliance, than in the SLT group, but that wasn't significant. These results support the option of SLT as a safe and effective initial therapy in open-angle glaucoma or ocular hypertension. I think it's a big deal coming out of Will's eye back in 2012, and this was really the study that caught our attention. Goes, all right, it's been drops, and then it's been laser, and then it's been surgery. Laser should be moving this way towards the drops, and we can start to evaluate using this first-line therapy when it comes to SLT. Again, we were a little behind the times. Here's a study out of Israel back in 2003, and you'll notice this was an 18-month study, and they got a 30% drop in IOP. What do you expect for your first-line drop? If we asked a question, I bet most of you would say approximately 25 to 30% drop in IOP. They got it here with SLT as primary therapy. It held for the 18 months of therapy. Again, in other parts of the world, it's been first-line therapy for quite some time. How about SLT? You know, and up to date, this is a big medical database that our medical colleagues, our MDs and DOs use, the most up-to-date information on everything from heart disease, you know, brain surgery to ophthalmology as well. Once the decision has been made to treat with open-angle glaucoma, we recommend drops or laser. So it's now one or the other. When you're treating first line, you just diagnosed a patient with glaucoma, you're making that initial decision. What should I use? You can go to drops or you can go to laser. It's not one then the other, it's one or the other. You can pick and choose at this point in time. And I think, as we all have seen, SLT offers some unique advantages. Meta-analysis in 2015, there's huge evidence that SLT may be offered as a primary treatment to patients with open-angle glaucoma. Here was the big one. I'm sure most of you guys are aware of this trial. If you haven't seen this, if you haven't read this, I would encourage you guys to work through this trial. It is the LIGHT trial, and this was released in March of 2019. This was out of the UK, and it was, what was the downsides of the SLT med study? If I go back to the SLT med study right here, there wasn't a huge N number going down each arm. Notice we've only got subjects in the 30s in each group, and this was only a 1-year study. We want to know how does it do longer than 1 year out, and the LIGHT trial was that helped to answer that question. Number one, there was hundreds of patients that went down the SLT arm and hundreds of patients that went down the prostaglandin arm, and this was a 3-year trial, or data was assessed at 3 years. If you look at the summary here, what was their interpretation? SLT, not could be, SLT should be offered as first-line treatment for open-angle glaucoma and ocular hypertension. And to me, if you wait for this last statement, this is a huge statement supporting a change in clinical practice. We've all been trained, again, over the decades, as we've talked about. This study was one of many saying we really should have a change in clinical practice of SLT as first-line therapy. You know, going into the data here, I think this was big data on the 3-year LIGHT trial, just kind of hitting on the key points. We've already covered the clinical conclusion, as you can see near the top, should be offered as first-line therapy. 3-year trial, huge N numbers. There was 5 times less adverse events if you went down the SLT arm compared to the drop arm. Less redness, less irritation, stinging, burning, you know, things like that we know can happen with drops. Certainly adverse events can happen with any therapy, including SLT, but 5 times less likely with SLT. To me, the biggest one, what was this 4th bullet right here? 78% of patients at the 3-year mark were drop-free if they went down the SLT arm. 78%. I quote this for our patients now when we talk about SLT, and they ask, Doc, what would you do? Well, if it was my eyes, I would want an SLT first. And the data is now pointing us towards that there's an approximate 78% chance that you can be drop-free 3 years in. Wouldn't you like to give your patients 3 years of drops free? We just diagnosed them with glaucoma. We can put them on drops, or we can keep you off of drops for at least 3 years, maybe longer. To me, that's the big bullet, that fourth one right there. And of the patients that went down each arm, if you had a drop first line, 11% of patients progressed to the point where they needed surgery during this 3-year trial. Why do you think that is? Again, they were just diagnosed with glaucoma. The baseline characteristics were the same. It wasn't as there was severe glaucoma in the drop arm and mild glaucoma in the SLT arm. Baseline characteristics were the same. Why did some patients that were on drop therapy need to have surgery throughout this? Probably highlights compliance, right? They weren't taking their drops as needed. Notice none of them that had an SLT needed surgical intervention. Again, I think this is a big deal when it comes to the Light trial released 1 year ago, last year in 2019. So once again, your indications. We've went over these already. I'm going to hit on them one more time, and I've listed these in probably the most likely indication or the strongest indication down to the least likely indication. All of these are indications, but POAG is number 1. Ocular hypertension is 2, low tension is 3. Those are going to be your top 3. Certainly pigment dispersion and pseudoexfoliative, are they indicated? Yes, but it's a little bit higher risk. Take it with a grain of salt. Be prepared to maybe not do as many shots and watch for adverse outcomes or adverse events, I should say, like IOP spikes and inflammation, maybe more likely to happen in those last 2. Contraindications, everything that we talked about before. Risks. You know, to me, this is an extremely safe laser. Yes, do we have IOP spike, inflammation? They are there. That's why we put in drops before and after the lasers, like brimonidine or alphagan before, brimonidine or alphagan after, in office. It's never wrong. And based on my training and the way I do things clinically, is we put in a drop of brimonidine before we do lasers and a drop of brimonidine or 2 after we do the laser as well to help blunt the risk of an IOP spike. The literature says it's approximately 3 to 5%. I would say it's probably closer to 1 to 3% when you pre-treat with and post-treat with brimonidine. IOP spike, inflammation, stromal haze edema can happen. I've seen it happen twice. It's out there in the literature in my clinical experience, but it's very rare. Peripheral anterior synechia as well. I've never seen that happen. That risk is much higher with ALT compared to SLT. This is a very safe laser. Nothing in medicine is perfect, but your rates of adverse events, IOP spike, inflammation, haze, other things are very low. Obviously, we watch out for that. And you know, you go to the second one, inflammation. How does this laser work? Biologic, inflammatory, light stimulation, you know, sublethal photostimulation. It's not photocoagulation, it's light therapy. Light laser is stimulating a little inflammation. So you want some inflammation there. Can you get too much and get a trabeculitis and cause an IOP spike? Yes, but we want a little inflammation there. That's how the laser works. There's our pre-op, our laser settings. When I do an SLT, I typically dial in between 0.8 and 1 millijoule. We adjust that based on pigment. The more pigment they have in the meshwork, the lower we dial down our energy. The less pigment they have, the more higher. We're going to take our energy maybe to 1.1 or 1.2 millijoules if they have minimal pigment. But most often a nice starting point, typically somewhere between 0.8 millijoules and 1 millijoules of energy. Patient's comfortable, you're comfortable, obviously prepare a cane, and we put the laser lens on the eye. This is the laser lens that I was trained on. Great lens, fabulous lens, the Latina lens, named after Dr. Mark Latina, who's really credited for coming up with SLT. 1 mirror, 1-to-1 magnification in terms of your view versus the laser energy going into the eye. It's a fabulous lens. This is the lens that I used for the first 8-9 years of myself doing SLTs when I was training students and residents as well. Great lens. Downside, 1 mirror. So when you're going all the way around and you're doing a 360-degree SLT, that mirror needs to be rotated 8 to 12 times as you're going all the way around, which certainly is not a problem. Typically, when I'm doing SLTs, it takes anywhere from about 3 to 6 minutes per eye, depending on the patient, you know, how cooperative they are, etc. So 3 to 6 minutes per eye. And I have switched to the rapid SLT lens. And again, both are fabulous lenses, but this lens was released approximately a year and a half ago. And you'll notice this is distributed by Volk, and it's a 4 mirror. So instead of 1 mirror, we've now got 4 mirrors. And there's a reason it's called the rapid SLT lens, because when you have 4 mirrors, it's really made our procedures happen a lot quicker. By my estimations, a 3 to 6 minute procedure per eye is more like a 2 to 4 minute procedure. So I've estimated it's cut my time down by about 30 to 40%. So if I can do a procedure in 2.5, 3 minutes instead of 4.5 or 5 minutes, to me, that's a benefit for the patient. They've got the lens on their eye much less. So I've really enjoyed it. I was actually hesitant because you like what you're trained on. I was trained on the Latina lens, and I used that from 2009 to 2018, 2019. I think it was late 2018. And, I was like, this is what I like. I'm used to rotating the lens. This is how I do it. I'm in my routine. I'm in my groove. So it took a while. But once I finally, grabbed a hold and said, you know what, I really need to look at this, it's been awesome. And so I really enjoy this lens. 4 mirrors. I put it up here, so I have mirrors at 12, 3, 6, and 9. So you can tell if you guys can see my cursor here or not. But the mirrors at 12, 3, 6, and 9. 12 to 13 shots per mirror. And we go along, and after you do those 4 mirrors, I rotate it 1 time to the obliques and do 12 to 13 shots in each mirror again. Do the math, that gives you approximately 95 to 100 shots for a 360-degree SLT with 1 mirror rotation, which makes it very, very nice. So spot size comparison, again, ALT and SLT, I'm going to skip by this for time purposes. Remember that SLT, it's gentle on the tissue. There's no destruction of tissue. There's no photocoagulation. So in theory, it's easier to do. It's easier. The pressure is less on. Not that you want to shoot other parts or miss other parts of the meshwork. You want to be on the TM. But if your patient moves and you got into the ciliary body, you're not photocoagulating. Many ophthalmologists that I was trained under that have done extensive ALT and extensive SLT say this is easier to do than the ALT is. We adjust our energy. We do 360 unless they have significant pigment in the trabecular meshwork. Let's watch a couple of videos in our last 6 minutes here before we start our question and answer. So this is an SLT. I'm gonna fast forward this here just a little bit. There we go, up to this quadrant here. This is an SLT that I did. This is in 2013 or 2014. You can see a nice view here. We've got our 1 aiming beam. And you'll notice nice view, just cover the trabecular meshwork. That posterior pigmented trabecular meshwork is critical. You're seeing the champagne bubbles. You want to titrate to the lowest level that produces champagne bubbles, the lowest energy level that produces champagne bubbles. So if you're on 0.8 millijoules and you're seeing champagne bubbles after 3, 4, 5 shots, you should go down to 0.7. If you're seeing champagne bubbles at 0.7, you go down to 0.6. You're seeing no champagne bubbles at 0.6, you go back up to 0.7. Obviously, we're not firing right there. We're just getting aligned here. And we're ready to go and basically do this mirror. And we'll do 8 to 12 shots in this mirror. And then when we get to the other edge of the mirror, we will rotate. Nice crystal clear focus on the trabecular meshwork here. And again, we've just finished 1 quadrant. We started at 9 o'clock. We're up near 12 o'clock. You should be about 25 shots in. There's a mirror rotation. And we'll just watch about half of this one here as we go along. Again, I started at 9 o'clock. Where are we at now? We're at about 1 or 1:30. Just going along. Notice you don't see any laser burns. There's no pits. There's no craters. You actually cannot tell any difference between where we're about to treat and where we just treated because there is no landmarks in terms of laser damage to the tissue that you're treating. And again, if we started at 9 o'clock, we are approaching 3 o'clock right there. So we should be approximately 50 shots, give or take, 5 or 10 either direction. And you continue along. Notice we've rotated the mirror 3, 4, 5 times at this point. That was with the Latina lens. Here is a video with the rapid SLT lens. And just giving you an idea, there's a nice view. This is a top mirror. We're already going. You can see our champagne bubbles right there. 12 to 13 shots approximately in that mirror. And then we're working down in this mirror here. And this is the Volk Rapid SLT lens. This video is about, I probably took this 9 months ago or so. And really the art of this procedure is the laser lens. It's tilting and turning and giving yourself the best view of, hone your gonioscopy skills. If you're comfortable with a laser lens, or with, I should say, a gonioscopy lens and doing gonioscopy, you're going to be a whiz at SLT, again, tilting and giving yourself direct access to the trabecular meshwork. Notice we're 3 mirrors in already. We're working up our 4th mirror. We have not rotated at all yet. We did the top mirror, the right mirror, the bottom mirror, and now we're in the left mirror. And once we get to the end of this mirror, we're going to, here's our 1 mirror rotation right there. That's it. And now we're in the obliques. We're ready to go on mirror number 5. You can see the little champagne bubble there, and we're doing the exact same thing in this right here. So again, there's a video of an SLT with a rapid SLT lens. I think you'll notice we're already half done on that, and that was barely over a minute in that case right there. So post-op, Alphagan, brimonidine, check their pressure. We always check their pressure approximately 30 to 45 minutes after the procedure. See you back in about a week for follow-up. Remember, the SALT trial is the steroids after laser trabeculoplasty trial. Really said you can use a NSAID, you can use a steroid, short term for a period of 2 to 4 days. You could even use nothing. Some give them nothing, but NSAID, steroids maybe boost the short-term results. This was just one trial, but it did say that maybe an NSAID, maybe a steroid for 2 to 4 days after isn't a big deal after SLT. Might be something you want to consider. 6-week post-op, see the full effect of that laser. Here's the last thing that I want to mention. How do we predict success on this? Expected IOP reduction is anywhere from 10 to 35, 40%, depending on when you utilize that. Let me ask you a question. What works better, your first drop or your third drop when you're treating glaucoma? And the answer is simple. It's straightforward. I'm guessing it'd be unanimous. Your first drop works better. What do you expect from your first drop? 20 to 35% pressure reduction. How about your second drop? Probably 10 to 15% pressure reduction. Your third drop, probably 5 to 10%, maybe 0 to 2 points. That's what our glaucoma specialist told me once. Third drop, expect 0 to 2 points, maybe 5 to 10%. So if you're using SLT as the third drop or as the 4th drop alternative, what should you expect for IOP? 5%, 10%, maybe a couple of points, 0, 1, 2 points. My point is SLT is most useful and most effective earlier in the course of therapy. It should be considered first line or at the latest after the first drop, so we can get that 20, 25, 30, 35% pressure reduction. There has been many, many studies that have looked at all of these different factors. How do we predict success? How do we choose that patient's going to do well, that patient's not? That patient's going to get a 30% pressure reduction and that patient is not. And what they have found time and time again is the biggest predictive factor for success is pre-laser IOP. The higher the IOP, the more likely they're going to get a 25, 30, 35% pressure reduction for primary therapy. Second one is number of medications. Pigment is in there as well. There's a lot of them, but the biggest one is pre-laser IOP. Makes sense, correct? If your patient has a pressure of 25 versus your patient has a pressure of 14, the drop is going to lower that to a higher percentage for which patient? It's going to be the 25. Just our drops work the same way, and SLT does as well. So I would encourage everyone to really think about that. When you're utilizing SLT, utilize it earlier in the course of therapy. It's more effective earlier in the course of therapy. You use it as a first drop alternative, you're going to get like a first drop pressure reduction, 20 to 35%. You use it as a third or fourth drop alternative, and you're going to get 5 to 10% at best, depending on the case there. Pre-laser IOP, number of medications, pigmentation status plays a role as well, cataract surgery plays a role as well, but bottom line, it's pre-laser IOP. However, don't forget about low tension. It's our third indication. POAG is 1, ocular hypertension is 2, and you can see why after the discussion that we just had. So the bad news about low tension is what I just covered, is this table going, it's not as effective when the pressure is lower, and that's absolutely true. What do the studies say? What should you expect SLT in low tension glaucoma? That's the answer. It's about 14 to 16%. So don't expect 25, 30, 35% pressure reduction with low tension, 14 to 16%. That's based on meta-analysis. But here's a big one. A big advantage of SLT is blunting those diurnal control of blunting those nocturnal IOP spikes. We know the pressure goes up and down and up and down and up and down. SLT has been shown to blunt. That's one of the biggest advantages of SLT is blunting those nocturnal spikes, basically diurnal control, big advantage of SLT. So is it indicated in low tension glaucoma? Absolutely. It's not going to lower the pressure as much, but it certainly is an indication, and it's going to blunt those spikes as well. Pigment dispersion, again, I'm out of time. Pigment dispersion and pseudo-exfoliation, just be careful. The more pigment they have, these are fragile glaucomas anyway, the higher the rate of IOP spike, inflammation, trabeculitis. So just be careful with that. Turn your energy down. We don't do 360 in pigment dispersion and pseudo-exfoliation. We do 180 degrees or less on that. So just be cautious with that. Long-term outcome, you can see it right there. When patients ask, how likely is this going to work on my eye? I tell them 80 to 90%. It doesn't work on anybody. Not everybody works. Not every procedure works on everybody, but we've got approximately a 90% chance. Choose your patients wisely. Earlier in the course of therapy, IOP, again, biggest predictive factor for success. It works better as primary treatment than secondary, and secondary works better than tertiary. It does wane with time. It's one of the perceived negatives, and I think it is a negative, is it's not going to last forever, but it tends to be very repeatable. Again, I'm out of time, so repeatability, very good with SLT. Bottom line is it might not work quite as well as the first one, but it's darn close. Repeatability is good on that. So summing up the positives, in my mind, it works 80 to 95% of the time. Remember the predictive factors for success: pre-laser IOP, number of medications that are on, pigmentation status, and again, it lowers pressure by about 20 to 35% in POAG, 14 to 16% in low tension glaucoma, tends to diminish over time. There's the code. You can see the code, reimbursement on average, global period right there. Cost analysis have shown that it is very positive compared to meds, meaning on a healthcare system, this is just as good, if not better, than drops because of the compliance issues that we all deal with. So probably a cost benefit as well. So my last question that I'm going to finish with, and then we're going to open it up to your questions. You know, let's say you're 65 years old. You're in that sweet spot that was just diagnosed with glaucoma. You guys are the experts, and you were just diagnosed with POAG. As the experts, what would you choose as first-line therapy if it was your eyes? And obviously, there's no wrong answer here. It's all, I mean, no, it's completely anonymous as well. Would you choose drops? Would you choose laser for your own eyes if you were just diagnosed with glaucoma? And again, there's no right or wrong answers on this one. You take a look at this. Again, you guys are the experts, well trained in all of this. Usually don't see 100% on that, but you know, it's typically when I ask this, and I've asked this question a lot, it's usually about 75 to 85%. You guys are a little bit higher. We've got a smaller sample size, but yeah, I mean, it's just a lot of benefits when it comes to SLT. So I think there's the traditional paradigm. In my mind, the new paradigm is we've got SLT first, meds are there as well. We don't push anybody to laser that doesn't want it. We've got good meds as well, but it's earlier in the course of therapy, as you can see. So with that, I know I'm 5 minutes long. I'm going to open it up for any questions.
Awesome. Well, thank you very much, Dr. Nate. We'll start off the first question. Why Lumenis SLT? Why would you recommend a Lumenis laser to a peer or colleague over other SLT options?
Sure. Well, Lumenis obviously was the first one that had SLT therapy. They've been around the longest. They've had the studies that have been proven on that. You know, they have the technology that's been proven over many decades. So they offer a lot of benefits because of that. You know, they were first out of the gates, and we know first out of the gates certainly goes through the challenges, the studies, the rigorous studies, the FDA, you know, all that stuff. So certainly a big advantage with that.
Perfect. Next question. It's a refresher question. You tilt your laser lens in the direction of the mirror you're treating to open the angle and visualize the TM better. Am I correct in thinking this? This is from Cameron Norman.
It's from Cameron and Norman. So you want to give yourself as flat an approach to the trabecular meshwork as possible. So when you've got the laser lens on the eye, and let's view it in really two parts. If your view is blocked and you want to open up your view to give yourself a wider and better view, you want to tilt your lens towards the blockage, meaning, okay, I need a better view to the left. tilt your lens to the left. I need a better view or more view to the right, tilt your lens to the right. So to open up your view, you want to give yourself a tilt towards the blockage. That's how I think of it, how I say that. So if your view is blocked on the bottom, tilt down, okay? You want to make sure that your laser beam is flush, meaning you want the beam, if you can see my hand, to hit a surface, a TM that's like this and not angled like this. So you want to tilt your lens, and yes, you are correct, in that direction. That flattens the trabecular meshwork, so you have your aiming beam hitting as flat a TM as possible.
Thank you. The next question we have is, do you know what states have pending legislation that would allow ODs to do medical laser procedures such as LPI?
Sure, it's a good question. There's obviously, as right now, I don't want to get into a whole bunch into the political stuff, but right now, Oklahoma obviously was the first, and Kentucky and Louisiana, Alaska, and Indiana, and Arkansas are the 6 that have passed legislation or are currently doing SLT. There are quite a few other states where this is certainly an interest. I'm not going to name the individual states. I'm happy to answer that question off the webinar, but there's quite a few. I mean, more than a dozen or more that we're looking at this. And in my mind, who treats glaucoma first-line therapy? You guys do. Optometry does. I mean, glaucoma specialists don't tend to treat glaucoma on the front lines. They are the glaucoma specialists, and they're seeing the advanced severe cases when they're on 2, 3, 4 drops. They need surgeries. When you look at data that says who's initiating the first glaucoma treatment, it's optometry a good chunk of the time, certainly the majority of the time. So in my personal opinion, this is not Lumenis's opinion, but I'm just speaking as Nate Lighthizer, this is ideal for optometry. When you look at the data, to me, it's a public service for that optometry should be able to do SLT first line, because it's equivalent to first line. It's very safe. It offers a 25 to 35% pressure reduction. You know, when I lecture live, I always say it's easy for me to recommend SLT as first line because I walk them across the hall and do it myself, or have our students and residents do it under my supervision. It's another thing if you were in private practice in North Dakota, let's say my home state. It's another thing where okay, I just diagnosed this patient needs to be on therapy for open angle glaucoma. Well, I can just start them on myself on a drop. That's easy. They're my patient. Boom, we're done. Or now I've got to initiate a referral and send them to somebody else that may or may not do the laser. So it's easier for me. Again, I think this would be a great thing for the public, for patients to be able to have optometry doing this, because you're all well qualified to do it, in my opinion.
Perfect. Next question I have is, what is your first line therapy for new PDS and PXG patients? Do you start with drops because of SLT risk?
That's a good question. You know, again, I'm going to, like every patient, I'm going to present them the options of, okay, we've got glaucoma. Usually there's been multiple visits of multiple IOP checks, visual fields, OCT to confirm the diagnosis. Again, usually we don't make a diagnosis based on one visit. We want to repeat the data. So we've had an opportunity to talk to them a few times about this. And during the course, I always mention, you know, we've got 2 options that we can go to. If we decide to go to treatment, we can go to laser, or we can go to a drops. And the laser is extremely gentle, doesn't cause any damage. It really is just a light that's causing your own immune system, your own cells, to help clean up the debris. So we can go to this laser therapy, or we can go to drops. Here's the advantages of each. If they make me pick, I tend to go to SLT as first line and just titrate your energy down. And we do less degrees. We wouldn't do 360. We do 180 or less. So if you had me answer, it would be SLT first line, but I do present them both options, and just follow them more closely, because your risk of IOP spike is a little bit higher in PDS and pseudoexfoliation.
Okay, I'll do 2 more questions before we wrap up. I know that we've gone over the hour mark, so thank you again. The question is, SLT as first-line therapy still recommends seeing patient every 3 months. Is that still the case?
That absolutely is the case. And I've heard that as a potential downside of SLT is patients will think they're cured then. Absolutely not. They are not cured. There's no cure for glaucoma at this point in time. this is like a drop. You still see this patient every 3 months, every 4 months, every 6 months, whatever you deem appropriate based on their level of disease, how advanced it is. So yes, we usually see them every 4 months. About 3 times a year is when we see most of our glaucoma patients. Sometimes it's every 6 months, sometimes it's every 3 if they have more advanced disease. But yeah, you should continue all of your IOP checks, visual fields, just like any other glaucoma patient.
Awesome. So last question. Do you do a short-term PGA trial before SLT to see if patients' TM will react similarly and have a successful outcome with the laser, similar to MOA? Or just do the SLT and add a drop later if needed?
You know, that's a good question, and it really goes into it in theory versus what you do practically in the trenches. We didn't have time to cover this, but prostaglandins and SLT have pretty similar mechanisms of action. They both are inflammatory and they both work on outflow. Now, uveal scleral versus trabecular meshwork, but there is some overlap between prostaglandins and SLT. So there is evidence out there, and there are some that believe that prostaglandin success predicts SLT success. Now, you may not want to pair them together because they work so similarly. Maybe you do, maybe you don't, but prostaglandin success predicts SLT success. So if you put your patient on a trial of a prostaglandin for a month and it lowers their pressure 35%, you can be confident that that SLT, once you pull them off the prostaglandin, is likely going to lower their pressure 35% as well. There is evidence that says prostaglandin success predicts SLT, so you could do a trial. That being said, do I usually do that? The answer is no. Just again, in the trenches of having to start them on a drop, you know, when is the redness usually the worst? In the first couple of weeks, you know, make them endure that. So I understand the theory, and I think there's some science behind it. In the trenches, I don't usually do that.
Perfect. So I believe that would cover all the questions we have this afternoon. Again, I would like to thank Dr. Nate Lighthizer for joining us today and doing this presentation. And I would like to take a second to thank all our audience for sticking around and joining us this afternoon. If you guys have any questions regarding this webinar, I will be sending a link to watch a recording if you missed it or if you just want to review it again. And Dr. Nate, if you have any last thoughts you want to share with us, we'd love to hear it.
Again, I would just encourage everybody, you know, a decade ago or more than a decade ago, I was a little bit going, man, this SLT doesn't work as well as I thought. And then I would look back and go, well, I know why it didn't work well. It's because the patient was on 2 or 3 eye drops, their pressure was 16, 17, 18, and we were using SLT as the 3rd or 4th drop. And yes, you're lucky to get a point or 2 at that point, just like your 3rd or 4th drop. So I would encourage everybody to just think of SLT earlier in the treatment paradigm, and you're going to have some nice results for your patients.
Thank you very much. With that, I'd like to conclude this webinar. Thank you so much again, and have a good rest of your day. Thank you.
Thanks, everybody. Have a great day.